Choudhary. The topic is minimizing temporary clipping in aneurysm surgery. Thank you.
Thank you very much for the opportunity. Before I start, I just have one declaration to make that I don't have any conflict of interest, but I do have a declaration for funding that I have been supported by a pharmaceutical company called Intas Pharma for registration and accommodation. With that note, I would like to start. This is just a thought and how my practice has evolved over the years. Does preemptive temporary clipping lead to harm in aneurysm surgery? I'm sure we all have our opinions and anecdotal experiences. There is conflict of evidence in the literature. There are no RCTs and the practices change from unit to unit. There are individual perspectives as well. The factors that influence outcome of temporary clipping are pretty much standard, whether there is subarachnoid hemorrhage or not, the grade, duration, site of temporary clipping, etc., etc. The traditional indication for temporary clipping, which are considered acceptable, is to facilitate safe dissection as a rescue clipping during rupture, to reduce the turgor or turgidity of the aneurysm, to allow suction decompression, remove thrombus, remove coil mass, reconstruct the vessel by remodeling. So they're all acceptable, traditional, no controversies there. What the literature supports is that the temporary clipping is not risk-free. Intraoperative rupture, temporary clipping can be life-saving. Poor grade patients can suffer more if there is a temporary clip. What is the duration of temporary clipping? 8-10 minutes enough? Or is it adequate or not? Controversy. Neuroprotective agents, do they really work? Age and the vessel that is being clipped temporarily as well matters. So there is a lot of literature around this and I don't have time to go through each of them. The thing is, the main controversy is, what is the safe duration of temporary clipping? From 0 minutes to 93 minutes in the literature. Continuous versus intermittent. I'm sure we all have our preferences. Intraoperative monitoring, is it really worthwhile? Does it change the outcome? Neuroprotective agents. I know there are several anesthetists and neurosurgeons who would swear by many of the agents. Do they really work? And my question to you all and to myself is really, is there a need for temporary clipping in majority of the cases? If there's an aneurysm like this that needs deflation and clip reconstruction, yes, I understand. You need temporary clipping. But for usual grade 1, grade 2, grade 3 subarachnoid hemorrhage, small non-coilable aneurysms, or even some unruptured or recurrent aneurysms, is temporary clipping necessary? My answer today is probably not. This is my review of cases of temporary clipping. I clipped about 40 to 50 aneurysms per year for a number of years. Recently, the number has gone down. But if you see the two last columns, over the last 25-30 years, the temporary clipping incidence in my practice has decreased. Intraoperative rupture has also decreased despite not using temporary clip. Recently, it has increased because I let most of my aneurysms being operated by my vascular fellows. So what I'm saying is, as my practice has evolved, I find it less and less necessary to apply a temporary clip preemptively. And I'm talking about rupture aneurysms. Very rarely I use temporary clip for unruptured aneurysms. This is 25 years ago. ACOM aneurysm, grade 1 subarachnoid hemorrhage. This is straightforward. There is controlled label is absent. This is the temporary clip applied and then permanent clip applied, aneurysm empty. Nothing wrong with that. Good outcome. Now, after 25 years, this is ACOM complex exposed with a small, tiny ACOM aneurysm rupture at the base of the ACOM itself. No temporary clip required for that section. This is a recurrent aneurysm. Well, I thought that was recurrent, but it's a de novo formation of A1, A2 aneurysm. all A-complex, anterior communicating complex dissection, no temporary clip required. Recurrent aneurysm with grade 2 subarachnoid hemorrhage, dome of the aneurysm dissected, neck dissected, again, no temporary clip required. So my reasons to avoid temporary clip is, it is almost unnecessary in my experience, in most routine cases. The effects of temporary clipping are unpredictable, no matter what we say. It does not necessarily reduce the risk of intraoperative rupture. In fact, it gives you a sense of self-confidence that could be actually counterproductive. Perforator injury is not always avoidable. We try, but it's not always avoidable. And it's easier for minimally invasive procedures like supraorbital craniotomy or endoscopic approaches not to use temporary clip. For example, for such this is minimalism. But in my opinion, minimalism in aneurysm surgery is not restricted to a minimalistic surgical approach. I recruited several patients for ISAC trial where the practice changed. Now, what is better with coiling is actually the minimal invasive and the effectiveness is same. Therefore, what we need to do in aneurysm surgery is to reduce the steps that are not necessary. And in my opinion, even in very, very experienced hands and in people who have operated thousands of aneurysms, I see them put in temporary clip that I think is probably not necessary. Simply that they have not changed their practice over the period of time. These are my surgical nuances that I find. Suction tips, very important. I use the smallest suction tip, but a normal suction. I use the ends on the suction tips, which I find very helpful to suck the CSF, but not to damage anything else. I use sharp dissection most of the times. I never use ball dissector. I don't retract. I'm sure most of us don't probably. I don't dissect the dome or the body unless it's necessary. It's the neck that we need, not the dome. And I use the turgor and the pulsations to my advantage when I'm dissecting on the aneurysm or on the neck. I don't have a video to show because I don't have time, only a couple of minutes left. But you can use the pulsation, and with pulsation you can separate and dissect the aneurysm and create a neck. And I like that. I think the best part of aneurysm surgery is using the pulsations of the aneurysm. Bigger the aneurysm, easier it becomes. And I use a tentative clip on the aneurysm rather than a temporary clip on a parent vessel. So if there is an aneurysm, I would put a clip on. I know it's not ideal. Then I will dissect it around, protect the ruptured part, and then remove it or apply a secondary clip on the neck. And I've developed that practice over the years and I find that really easy. So in summary, in my opinion, temporary clipping of parent vessel is usually unnecessary in non-giant ruptured aneurysms. Temporary clipping of parent vessel is almost never necessary in my practice in unruptured or previously coiled non-giant aneurysms. It is the only neck that needs dissection and exposure. Rest is usually unnecessary. So my message or my question to everyone is that we all strive to achieve perfection in aneurysm surgery. Minimalism is the key since we compete with coiling. So minimalism involves not only minimalistic approaches but minimize maneuvers and tissue handling. Avoid multiple and unnecessary steps such as preemptive temporary clipping. And most important is once we reach a consultant status and we are the seniors, professors, heads, clinical leads, whatever you call it, we should not stop learning. We should improvise. And one of the things to improvise is to reflect whether temporary clip that you have applied, is it really necessary and what harm it is doing. Please do visit our center. I do practice what I preach, and whenever my fellow is operating and is about to apply a temporary clip, usually a call comes to me so that I can come and scrub and see whether it's really necessary or not. Whether has it changed the outcome? Have I become a better surgeon? Have I improvised the outcomes than what were there 25 years ago? I don't have an answer because I don't have many thousand cases. I just have a few hundred cases at my disposal. Not good enough. But I think minimizing unnecessary steps is the key, and temporary clipping is one of them. Thank you very much. Thank you for the opportunity.
Thank you, Dr. Kishor, for a very succinct presentation and for finishing it in time. Questions, please.
Kishor, the use of temporary clipping, in my opinion, is that when you are just at the stage of dissecting the neck of the aneurysm, and you have some perforator or some branch which you want to dissect off the neck, at that stage, if you put a temporary clip, it is very, very safe and productive. See, intraoperative rupture of the aneurysm is something which can kind of mar your surgery, and the use of temporary clipping to avoid that, I think, is a useful adjunct. This is my opinion. And as you said, that as you gain experience and you evolve your techniques, the incidence of using a temporary clip does go down.
This debate about putting a temporary clip or not clipping is about 40 years old now. It's not nothing new about it. There are people who very strongly believe that what you said, don't apply temporary clip, and people who are on the other side. I think it has to be judicious use. If it is an atherosclerotic vessel, I think it's better always to avoid a temporary clip. That does create a problem. Otherwise, putting a temporary clip for 2-3 minutes for a ruptured aneurysm before, not only on dissection, but also just before putting the clip, because it reduces intorsion. And if you have a large wide neck and then you put a temporary clip, the clip takes the whole neck. Whereas if you don't, then maybe part of the neck is still there. The tentative clipping is the way to go, there is no question about it. And most of these things, what you said, most of us practice, but obviously there are 9 ways of skinning a cat.
Thank you, sir. Questions? So with that, we will conclude our session. Thank you all speakers. Thank you all. Thank you.
Thank you. Thank you all the chairpersons and speakers. Before proceeding towards second session,